We are live at the 11th Annual MegaGen Convention in New York City, and it is a supreme honor to be interviewing you today. Thank you so much for giving me some of your time, Dr. Langer.
Quite welcome, Howard.
I've been in dentistry 28 years. You've been in it longer. You're an elite periodontist in the biggest city in America. How has periodontics changed in your career from when you graduated to today?
Well, number one, some of the disease has changed. People are more conscious about their oral health. They are schooled in the proper method of brushing, flossing, going to the dentist. Their dentists are more acutely aware of periodontal disease, so you don't quite see the severe cases of periodontal disease that we used to get when I first went into practice on a routine basis. We still get them, but not the same in the same volume of patients.
So you're saying that there was actually more periodontal disease 30, 40 years ago than there is today?
I think so. And there are certain types of periodontal disease that we don't see anymore. For example, there is something called acute necrotizing ANUG that we used to see with people under stress. We rarely see it now. Once in a great while, we'll see something like that, but nothing like we used to see.
I'm going to ask you a very difficult question, and this seems crazy, but it's a really true question. You see dentists who see the mom every 3 months for a perio recall for 10 years, and they've never seen the husband. Now, if you were seeing her every 3 months for, say, chlamydia, wouldn't a doctor after 10 years say, maybe we should check your husband? You know, I mean, can you really treat a woman every 3 months for a perio and have never seen her spouse if she's going home and kissing him every morning, every night? Is periodontal disease transmittable above the belt, the mouth, like an STD is below the belt?
That's a great question. Actually, I used to feel that when I had the opportunity to see the husband or the wife and then the husband, the type of periodontal disease was very similar. And I used to say it's almost like it's a communicable disease. Women, of course, go to healthcare providers much more often than men do. But I certainly haven't studied it because our practice has changed so dramatically in the last 20, 25 years that I don't see quite the volume of periodontal patients and then see, let's say, women and then see their husbands. So I can't say that it's current, but I used to see that and I used to comment on it that it was very similar. If the wife had an advanced case, the husband did. Or if she had a moderate or a localized, the husband had it. Of course, I've never studied it, so it's just anecdotal discussions.
But if we do know a baby human is born without P. gingivalis in the mouth or Streptococcus mutans, I mean, they got to catch this from somewhere.
Yeah, I would think so.
Yeah. So when I want to talk about another subject, describe implantology from when you graduated to now, and how has that changed the profession of periodontology?
Well, that's a large topic.
Yeah.
Because when I graduated from Perio school, implantology was the treatment of last resort for patients that were desperate. There was no research done on it. I don't want to use the word carpentry, but the implants weren't sterilized. The surgical procedure was never defined. While some of them worked, there were many of them that were horrific outcomes that in later years we had to rescue.
Now, are you talking like subperiosteals and ramus?
All of them.
There were some crazy...
All of them. All of them. Some were good. Some, because of the resistance of the patient, did pretty well, but many of them deteriorated badly. And I have to say that while I never did many, I did some of them. I did some subperiosteals. I did a few blades. I did a few other things, but I was never pleased with it, and I gave it up because I didn't think that, as a health provider, that I wanted to do something that absolutely could turn really sour. But Professor Branemark changed all that.
And he just passed away last month.
He just passed away.
In Brazil.
But one of the most important people, I would say, in this 21st century, because his discovery paved the way for the introduction of implants into the dental field. As a periodontist, we never would have a program at the American Academy of Perio on implants. I think maybe I gave one of the first ones, and now I would say 80% of them have to do with implants.
So what was Dr. Brandmark's discovery?
Well, basically, it was twofold. One, working with on blood flow, he was able to put in these titanium chambers into the arms of his students to measure blood flow, the influence of smoking on blood flow, etc. Then on the healing of bones, he was also able to put the titanium chambers into the long bones of rabbits to see the effects, certain effects on healing. And when it came time to remove the devices, the titanium devices, they were fused to the bone. So what do they say? The prepared mind, discovery favors the prepared mind. He realized that he had something. And in Sweden, as you know, people lost their teeth very early. As a matter of fact, they were, the families oftentimes extracted all the people's, the young people's teeth before they got married. And so they had a lot of dental cripples. Those were the ones that he started his treatment on, plus or minus a few other ones. But that paved the way for the introduction of what we call osseointegration into dentistry, and actually in parts of medicine too.
Last month, we lost a legend in dentistry, Professor Branemark, who died in his retirement home in Brazil. He's from Sweden. What do you think of Dr. Brandmark? How did he change your profession at periodontology?
Well, first of all, he was the most important person in my professional career that I've ever met. I was interviewed, I don't remember, just recently about it, and they asked me about who is the most important person in your professional career. It took me about 3/8 of a second to say Professor P.I. Branemark. And the reason why he was so important is because as a periodontist, obviously we were trained to try and save people's teeth. And sometimes, to the best of our abilities, patients' mouths were going downhill. They were deteriorating. And we really didn't have any viable method of rescuing them to keep them away from full dentures. I was fortunate enough, before I knew things about Professor Branemark, I was fortunate enough to listen to him in the latter part of 1982. And he presented his life's work. Of course, he wasn't that old at that time, but what he had started in 1963 or 64 at the meeting, the Greater New York Academy of Prosthodontics here in New York. And he presented a carefully, scientifically well-documented results of placing implants in patients and having them survive in health with a steady state of bone levels for long periods of time. He showed it not only in the lower jaw, but also in the upper jaw. And when I saw it, I said, wow, this is something that we could use on our patients who are losing their teeth. And again, I was fortunate enough to get into one of the early training courses in Toronto, where he came with his group from Sweden to give us a week-long training, intensive 7 hours a day of training surgically, conceptually, scientifically, to learn the technique, which was kind of alien to me. And we started about a year later doing our first patient. And from there, it was straight uphill, I mean, for the patients. That I shouldn't use that term, uphill. It was a rescue for them because we started to treat these horribly deteriorating periodontal cases, and these patients were rescued. They couldn't believe that they had new teeth with no abscesses. They had very few problems afterwards. And it was really the biggest breakthrough in modern dentistry.
And he wasn't even a dentist.
He wasn't a dentist. That's the most amazing
Will you
thing.
tell the story to our younger viewers?
Basically, he was an anatomist and an orthopedic researcher in Sweden. He was studying. He was a professor in Sweden, and he was studying blood flow. So he commandeered some of his students to allow him to put these titanium optical chambers in a little pedicle in their arm. I guess he said, if you don't do that, we're going to fail you. But they agreed to allow him to put these chambers in their arms. And he studied blood flow. And one of his studies, by the way, was the effect of smoking on blood flow. And he could show that a person who started smoking, the vasculature and the blood flow decreased, which we know now is one of the effects of smoking. But the tissue was so well tolerated. Now, this was soft tissue around these titanium implants. It was instead of being an alien substance, it was almost homogeneous with the tissue. Then he was also, at the same time, studying the healing of long bones in rabbits. And again, he put in these optical chambers. Optical chambers mean he could look through the chamber into the site that he was studying. And when he came to remove the titanium optical chambers, he couldn't get them out. They were fused to the bone. And of course, brilliant people have that prepared mind. So he was able to take that, what he visualized, and of course studied under the microscope, and then realized that he may have one of the most important ways of putting a structure into the skeletal system and not have it rejected, because up until this time there was no way or no effective way to put a piece of metal into the body. For example, if you lost your ear and you wanted a hearing aid, you couldn't just screw something in, a piece of stainless steel, into your skull. When he discovered this, by the way, he was able to put in a titanium threaded screw into the skull, and it would be well received and not rejected. And this started the whole field of osseointegration.
For not just dentists, but orthopedic surgeons? And
for people who had, let's say, cancer and had to have part of their face removed. And they were, I hate to use the terminology, but they were freaks, because you would see them and half of their face was gone. He was able to use his discovery of the titanium screw to put in a series of screws and then have a prosthodontist make up some sort of a prosthetic device to look like a face and attach it to the person's face and rejuvenate the respectability of that person. I know he had given a lecture here to the plastic surgeons. I don't remember whether it was at Memorial or NYU, and he got a standing ovation, which he got every place he presented it.
So, Brandmark's company is from Sweden. It went on to become Nobel Biocare, which is Sweden. So let's fast forward all the way to 2015. It's kind of confusing for young dentists to look at the implant field. I mean, you see Nobel Biocare implants that are probably $500 more. And you see 20, 30 companies all the way down to $100 implants. So I want to ask you, is an implant an implant an implant? Is titanium titanium? What do you make of the 100% variance in price?
Well, we don't know. We don't know whether the lower priced implant is as good as the Nobel implant or another implant. The reason is Nobel at least studied the implants, so they know what the track record is, and they've analyzed it over the long haul, just like we have analyzed our implants. Lori, my wife, has a tracking system that determines, and we upgrade it every single day, of patients that we've treated, patients who come back, the success rate. So we know whether we're dealing with something that looks good for 3 or 4 years and then deteriorates, or continues to look good for all of these years, which at this point is, I don't know, almost 30 years, pretty close to that. These other implants, while they may be just as good, we don't know if it's a similar type of titanium, but there's no studies on it. So, getting back to your question.
So from your research with you and your wife, so you're a husband and wife periodontist team.
That's correct.
And you've been married 42 years?
Right.
So you should get a Nobel Prize.
That's for sure.
Something. And
or she should get a Nobel Prize.
Or she should get a Nobel Prize. So in your 42 years, are there some companies you like? Are there some you should avoid? Or
Yes, there are. Well, I should say that I like some companies because the success rate of doing them seems to be quite good and similar to what we have at Nobel.
Can you share names?
If you want me to.
I do, because my whole motto is with Dentaltown, no one has to practice so look at. So there's some woman dentist driving to work all by herself. She's got an hour commute. She's all alone. And she's sitting there wondering, dude, you're a rock star in New York for 40 years. What advice would you give her?
Well, we use, as I said, Nobel. We use Straumann. We use 3i, which is now Biomet. I've used some Megagen, and they seem to do fine. But, people say, well, why don't you use more of them? And I said, because we have such a large inventory of implants, we can't use everybody's implant. One of the reasons why I accepted to lecture here is because Dr. Park did develop some really good surgical instruments that I use all the time, and I think it's terrific. So, he's a smart guy. If you read his textbook, and I'm not saying it to make the Megagen people happy, but...
Can you hand me the textbook?
So I would think, as I say, I haven't done any studies on Megagen implants, but I would think he'd probably have a very good implant.
So this is the textbook you're talking about?
That's right.
So I don't think... so are there any companies you don't like?
Well,
have some not worked?
There were... In the early years, there were some cylinders made out of plasma sprayed. Actually, Straumann had a plasma sprayed implant that was not really threaded, etc. And there was a company, IMZ, that had hydroxyapatite cylinders that looked great for 3 or 4 years. In the 5th year, they got violent breakdown. That we had to remove. We had a bone graft to get them back, and we put in Nobel implants, and they've done fine for the last 15, 20 years. So, there's a lot of aspects to implants, but these cylinders were not good, either because of the geometry, that they weren't threaded, or the surface treatment, either HA or plasma sprayed, that caused this destruction.
So do you think that's the end of HA, or is that kind of gone now?
No. Actually, what's interesting is Nobel bought a company called Stereos, which had a threaded HA.
Where were they at? Was that Sweden?
No.
Switzerland?
They were on the West Coast. I think it might have been California.
Oh, California.
And they had a
Stereos.
threaded implant, a threaded HA implant. they disregarded it, but I've used a number of them, not a lot, but a number of them, and they've done very well. But, once they discarded it, then, there was no other that I knew of threaded implants that I was going to try. But I think the story really isn't totally in on HA.
Okay, and what percent of your implants are you bone grafting around? Can you talk about bone grafting?
Yeah.
Is that something if this dentist wants to get into implantology and start placing some single implants for a missing tooth, do they need to get into bone grafting? How?
Probably.
For single tooth replacement?
Probably.
Talk about bone grafting.
Well, actually, when you take a tooth out, which I'm going to show this afternoon, we have always believed, people didn't always agree with us, but we've been doing it since 1989, extracting a tooth and putting an implant in and bone grafting it at the same time, and a success rate, which I'll show this afternoon, is not only as good as placing it in a healed site, but it's slightly better. Because when you take we'll call it an infected site or a damaged site, and you change it from a pathological entity into a surgical entity, sometimes the repair is so dramatic that it's better than if you extract a tooth, let it heal and let it collapse and then have to go back. Now, people fought with us about this and said, well, you can't do it, etc. Now these people are proponents for this treatment because we have the proof and other people have the proof too. But in order to do that, you have to know how to bone graft it. You should know how to suture it, how to close it, do all of those surgical things that we do on a routine basis.
So Dental Town now, we're just coming up to 200,000 members. How could we get an online course for you on Dental Town? We would love to have.
Well, I must say that I am, we do surgery every day. I don't give courses on surgery. And why don't I give courses on surgery? Because I'm not convinced that a person who takes a weekend course, and I'm not against the general dentist doing some of these things, but I think some of them are doing it and getting slightly above their training. But I think if I was a general dentist, I would make sure I could do the prosthetic phase of it, which they are trained on a daily basis to do it perfectly, because the prosthetic phase oftentimes is a major cofactor in the long-term success of implants.
So I want to switch gears. I think we both realize that 90% of the general dentists in America are never going to place an implant.
Right.
So I want to switch gears. So this is April next month. 5,000 kids graduating from dental school. I want you to talk about it's tough when you're a young dental student and you're trying to treatment plan dental implants, because sometimes you see a missing tooth and it's a first molar and all you see is a sinus cavity, and they're like, gosh, I don't even know, does a sinus lift even really work? Is she a candidate for a sinus lift? And then the second question you get is, well, this person's got gum disease and this tooth is wiggly and loose. I mean, I can't pull a tooth and then put an implant in an area where she's got full mouth gum disease. So switch gears to the diagnosing and treatment planning for these kids walking out of school next month. Are sinus lifts predictable? Do you place implants in people with gum disease?
Well,
talk treatment planning.
Yeah. Well, first order of business is, for the most part, you should treat the periodontal problem first, because you don't want a mouth that's teeming with bacteria when you're doing implants. Does it always work out that way? No. But that's the first course of business. For a young person that is going into practice, be it in his office, his own office, or going to work with somebody else, there is another aspect. I believe that the practice management of what could be done for patients is often missed. People, I've told the powers that be, but they don't listen to me, that if a dentist, be it a young dentist or a dentist that has a practice that wants to bolster their practices, wants an honest, quick way to bolster their practice, it would be to take people who are wearing removable prostheses and tell them they have the opportunity to have a fixed prosthesis. We're thinking of at least one person that we know who has been in practice much longer than I've been in practice, and he's transitioned his whole practice into an implant style practice by converting people who were in the mode of wearing removables and things like that into fixed bridge work. And if you can believe it, he's in his 80s and his practice is so viable. And I've said, for people who want to rejuvenate their practice, they have to, as they call it, the paradigm shift. They have to look at their patients and see that they have a wealth of new patients in their old patients by educating them of what is possible now.
And I want to say something to the young kids also. You know, dentists, physicians, and lawyers, there's a lot of book smart people who aren't street smart. Like a lot of times when a young dentist wants to learn some information, they fly clear across the country, pay $4,000 for a course, have to stay in a resort, all that, to just learn this much. I was street smart. I was amazed when I got to school. I could call a local periodontist or an endodontist and say, can I come in and talk to you? Can you help me set up a perio program in my office? Can you help me educate my hygienist of the diagnosing, when we refer, the whole deal? I got all my CE for free. How you're in Manhattan? How available are you to young graduates that come to Manhattan? I mean, do you mentor kids if they call you, or?
Well, I speak to them on the phone, but I work like a maniac.
Mm-hmm.
And my days are really busy.
Right.
So I don't have much time to mentor young people. Of course, I get emails from a variety of different either specialists or other people about problem cases, and I answer them back. But of course, time for me is the biggest commodity because I don't have much time.
Right. It's people, time, and money.
People, time, and money, and I work full time, and I'm fully booked almost all the time.
And that's why I know it was an honor to be able to get you today to do a podcast. I want to thank you so much for spending time with me today. Thank you for all that you've done for dentistry, everything you've done for periodontics. Can I just end on one question?
Sure.
One question. What would you say to a senior in dental school who's wondering if they should go into a perio program? There's 9 specialties in the ADA. Would you recommend a senior in dental school go into perio
That's
in 2015?
a real tough question because I'm not sure that it might be the best choice right now. We feel that the periodontal, the Academy of Perio and the periodontists have diluted the specialty. And I don't know that there's a lot of periodontists that don't have enough to do. Because of that, the generalist is doing a lot of it themselves because they've taken these courses given by periodontists. And I'm not saying we should be so proprietary that we don't help the young general dentists, but you can't give them the impression that taking a weekend course is the same as going to school intensively for 3 years. So I'm not sure which is the best specialty at this point.
All right. That was great words of wisdom. Thank you again so much,
Howard.
Doc. Bye-bye.